I have chosen today the physiological basis of Huntington disease and other basal ganglia disorders. The picture I have depicted here have two components. One, the picture of a person who first described the Huntington disease, Dr. George Huntington. In 1872, he described the entire clinical picture of the Huntington disease. And on the left-hand side, we have here the coronal section of the cerebral cortex, showing the normal pattern of the various parts, especially the basal ganglia parts. You can see this is a basal ganglia, this is a putamen and globus pallidus externa, interna, and caudate and thalamus some here. In case of Huntington disease, how does it look like? You just see that you have to discover the basal ganglia areas. You have a scanty areas. See, this is the area here, this is the area here. Scanty areas here, the basal ganglia areas. Same thing this side. There may be the side differences, but this is a basal ganglia Huntington disease affected brain, and this is a normal brain. I'm just showing that and see the difference. I will discuss about it when I take up those slides. Very quickly, there are 5 basal ganglia nuclei: the caudate nucleus, the putamen, the globus pallidus externa, globus pallidus interna, the subthalamic nucleus, and the substantia nigra. The substantia nigra, you have a pars compacta and pars reticularis. These are the parts of the basal ganglia. Now, the functions of the basal ganglia are planning, programming, and sequencing of the voluntary movement, execution of the pattern of movements that involves the putaminergic circuit, executing the cognitive control of the voluntary action, the timing of voluntary action, scaling of voluntary action, maintaining the muscle tone and posture required for the voluntary action, and dampening or attenuation of the oscillations of agonist and antagonist group of muscles. And it acts as a switch for the control of voluntary action, that is a turning on and turning off. With this brief picture of the functions, now let us see what are the disorders of the basal ganglia. Yesterday I mentioned about it: the Parkinson's disease, the Huntington disease, Swindenhams Korea, the Ballismus, Hemiballismus, Dystonia, Tourette syndrome or tic, the Wilson's disease, that is hepatolenticular degeneration, Kernicterus, that is hyperbilirubinic situation, and the tardive dyskinesia, that is produced by the doctor iatrogenic. The one I have made, the red ones, the Huntington disease, Swindenhams Korea, Wilson's disease, Kernicterus, and tardive dyskinesias, they all have one common feature. They have a chorea, that is a hyperkinetic movement in their presentation. The chorea is a type of a movement disorder which results in which produces unpredictable involuntary movements without any specific pattern. There are no specific pattern. You may be doing like this and then this like that. Anyway, even including from the facial, lips, the eyes, and then the fingers and so on. These are the range of the movement or the symptom may be from a mild jerking to a worse uncontrolled movements. Uncontrolled movements means the person is tired of moving the limbs or the arms and the legs. So that is what the chorea is. So these five particular diseases, they are concerned with the chorea. Now, let us get back to the discussion, the Huntington's disease. Huntington disease is a neurodegenerative disease affecting the younger age groups of 30 to 40 years. It is due to the loss of GABAergic neurons in the striatum, especially the caudate nucleus. And also in the later stages, loss of cholinergic neurons in the neocortex, especially the prefrontal area and other areas of the cortex, that is where it involves the learning and memory. This is the associated, Huntington disease is associated with the hyperkinetic distortional movements with dementia. It will start with the alteration in the movements, then dementia sets in. This dementia is related to the cholinergic neuronal loss. It's a progressive disorder, as we have seen with the Parkinson's disease. Now, here is a picture of the coronal section of the brain, wherein we see, this is a normal brain. You see the thalamus, then this is caudate nucleus. This is caudate nucleus. This is putamen. This is a globus pallidus externa. This is globus pallidus interna. A very bit. This is claustrum. This is forms the internal capsule, and we have a subthalamic nucleus here. Somewhere here you get the substantia nigra. This is the normal picture of the brain with these things. And whereas in the Huntington disease, you just see that this is ventricle, this part is the ventricle, and now this ventricle is expanded. You can just see that the ventricle is expanded on both sides. Maybe the expansion is not uniform on either side, but this is more here on the left side there, and it is less here on the right side. And but what is happening? These areas of the basal ganglia, absolutely they are reduced to little. A very little part of the basal ganglia are left with. Here, a little more here, and it is absolutely diminished. So that means it is the very the late stage of the Huntington disease, wherein all parts of the basal ganglia are destroyed. What is it due to? You know that 5 out of 100,000 people worldwide suffer from this disease. And this disease affects the younger age group, that is the age group between 30 and 50. If you are looking at the Parkinson's disease, it starts after 60. So that means this 30 and 50 age group patients or young people, they are still in the productive age. This Huntington disease is an inherited autosomal dominant disorder. And this inherited autosomal dominant disorder is due to the abnormality in the gene located near the short end or short arm of the chromosome 4. And this short arm of the chromosome 4 codes for a protein, what is known as a Huntingtin. So this protein is named as Huntingtin. This Huntingtin is present in even in a normal healthy individuals, normal healthy brain, also it is expressed and it is present. And it is performing certain functions. But when Huntingtin accumulates greater than required, so it is poorly soluble protein. And because of the poor solubility, it aggregates and accumulates in the cell nuclei. especially the neuronal nuclei, and this aggregates become toxic. So once it accumulates in the cell nuclei, it becomes toxic. So normally the chromosome 4, it has, for this Huntington, these are the CAG repeats required. It normally have, the chromosome 4 normally has 11 to 34 site CAG repeats. CAG means cytosine, adenine, guanine, nucleotide repeats. And this CAG repeats is the code for the synthesis of a glutamine, that is the part of the Huntington molecule. So that means the CAG repeats, they are between 11 to 34 repeats. So that means if I go for a genetic analysis and if I can know the CAG repeats, so then I can understand whether I will be prone for Huntington disease or not. If the CAG repeats are greater than 40, sometimes they may exceed as high as 80 or even 100. And when those repeats are more, that is happens in case of Huntington disease, where large amount of Huntington is produced and accumulated or aggregated in the basal ganglia area, or even the areas with the GABAergic neurons and the acetylcholinergic cholinergic neurons. In Huntington disease, if there are more CAG repeats, more Huntington is produced. And if the onset of the age of onset of this disease is at the earlier, then it will be more dangerous, as the progression of the repeat becomes faster. This is about the genetically inherited disease, Huntington disease. There are Huntington disease also can be produced by number of other agents. So because I focused myself for basically the genetic component or a genetically inherited disorder. In addition, the environmental factors like toxins or chemicals can alter the metabolic aspects and then may produce the loss of the striatal neurons. Now, what are the manifestations of the Huntington disease? The Huntington disease manifests as a jerky trajectory of the hand when reaching to touch a spot, especially toward the end of the reach. So that means as the person trying to reach, there may be a twist. So this is the beginning of the Huntington disease model, and slowly it tries to manifest as a chorea, that is a jerky, unpredictable movements. They are of a different magnitude and involves all parts of the body. Athetosis, these are slow, regular writhing movements of the agonist and antagonist group of muscles. Dystonia is the spasmodic, something like a spasmodic contractions of the muscle. These all three it will develop. In addition, the Huntington disease manifests as a rigidity, and because of the rigidity, there is a gait abnormality. The person walking suddenly throws himself and he throws his limbs, and he may fall down, or he may not have the proper normal gait of an individual. Unlike a predictable shuffling gait or fascinating gait of the Parkinsonism, you don't see such type of gait. Here you see a very unpredictable dancing like gait, as if the person is dancing to reach a target. So something like that type of gait you see. You will have the eye movement and the facial movements. Maybe he may try to wink and twitch, and he tries to move the lips, tongues, and all parts of the face. Now, because of the jerky motion, the speech becomes slurred and it is incomprehensible because the production is altered. And as the disease progresses, the hyperkinetic choreiform movements appear and gradually increase until they incapacitate the patient. Incapacitate the patient means patient is all the time, even during sleep also, he will be just throwing out the limbs like this, that, and that, and that. So that is the very agonizing aspect. You can go to Google and check the choreiform movements. Besides this, this is all due to the basal ganglia component. Then comes what happens? There is a loss of the cholinergic neurons. These cholinergic neurons are necessary for the short-term memory and other learning abilities or cognitive abilities. So that means this is associated with the loss in the short-term memory and the poor attention that is setting on to the dementia. And these patients will manifest with a depression, anxiety, and they have suicidal tendencies. What happens? The disease is progressive, dementia sets in, and after dementia sets in, he is not able to do any useful work. All the time his muscles are active, but no useful work is done, and death occurs because of the pneumonia or other things, injury or anything, and this will happen within 10 to 15 years after the onset of the symptoms. So that means the disease progression is fast, and within 10 to 15 years, the person dies. This is about the manifestation of the Huntington disease. Now what happens? Because as a physiologist, I am interested what happens in this individual to the basal ganglia circuitry. Here is a basal ganglia circuitry which I have discussed earlier. You have the direct pathway from the cortex, striatum, the D1 containing neurons. These are D1 containing GABAergic neurons reaching to GPI. From GPI, it will reach the thalamus, and the thalamus to motor cortex. The motor cortex gives to the corticospinal tract and crosses to the opposite side and controls the limb activity. That's one part. And you have from GPI and SNR, there is a additional output to the pedunculopontine nucleus or pontopeduncular nucleus, controlling the posture regulating mechanisms. That is the direct path. So this is the direct path. So then we have another path that starts with the premotor cortex. Then it comes to the striatum. So here is the D2 receptors. Then comes the globus pallidus externa, and from the globus pallidus externa, it reaches the subthalamic nucleus, and subthalamic nucleus, it will talk to the globus pallidus interna or substantia nigra reticularis, and reach to the thalamus and motor cortex and subsequent these things. In addition, these D1 and D2 loops are fine-tuned by the substantia nigra situated in the midbrain, and this is fine-tuned by that, and this substantia nigra will have a projection to the D1 receptors and the D2 receptors. And intrastriatal cholinergic neurons, they are also fine-tuning with the muscarinic receptors and nicotinic receptors. Muscarinic receptor is inhibitory, and D1 receptors are excitatory to these direct pathway neurons, and nicotinic receptors are excitatory, and D2 receptors are inhibitory to the indirect pathway. So this is what happens in case of the basal ganglia normal basal ganglia circuits. Now, in case of the Huntington disease, in the initial stages, what happens? There is a loss of D2 receptors or the GABAergic neurons in this pathway. That means this is an indirect pathway. This is a striatum and a pallidum, the pallidum externa, globus pallidus externa. This pathway, it is the defective here. So it is diminished, or there is an involvement, loss of these things. Either the D2 receptors are lost, or GABAergic neurons are lost. Now what happens? Input to the GPE is diminished. If the input to the GPE is diminished, the output of GPE enhances or increases. Now, the output of this GPE is coming to the subthalamic nucleus, and subthalamic nucleus is sending whatever the output going from the subthalamic nucleus to GPI is diminished or is decreased. And the GPI in turn gives a, it receives both the direct pathway and indirect pathway. The direct pathway is inhibitory. There is an inhibitory thing is there, and less excitation. This is excitatory. This is less excitation. So what happens? This output is decreased because it suppresses the GPI activity. And the output going to the thalamus is suppressed. So now from the thalamus, whatever the output goes to the motor cortex or the thalamocortical projection, it is enhanced. So that is why I have made the changes in the line strengths or the line widths to indicate what is happening. So here in the initial stage, it is the loss of these GPE or striatum GPE neurons, GABAergic neurons. I have summarized it. From the premotor cortex, there is a loss of the D2 receptor or loss of indirect striatopallidal tract. Now, what is happening? The GPE output is increased, and that decreases the subthalamic nucleus output, and that decreases the GPI output, thus increases the thalamocortical output. So that produces the hyperkinetic motion. That's the beginning of the story. That is the first time he starts demonstrating the signs of the Huntington disease. Then what happens in the next stage? Next stage, there will be loss of the cholinergic neurons, because I said the Huntington disease is not purely the GABAergic neuron loss. So there is a loss of the cholinergic neurons, not only the cholinergic neurons of the caudate nucleus, the cholinergic neurons of the prefrontal cortex, the hippocampus, and other areas of the brain. Now, what happens? The cholinergic neurons are lost. I have put a cross here with a style choline. And when the cholinergic neurons are lost, so the output or the muscarinic inhibitory inputs are diminished or absent. And that means the excitatory part of the D1 receptor is uninhibited, so that there is a more output coming from these neurons. This output is inhibitory, that inhibits the GPI. And once it inhibits the GPI, it will inhibit the output going from the globus pallidus interna to the thalamus, and thus enhances this output further. Look here, this is not altered. This is already existing. In addition to this, this is the beginning part, and this is the subsequent part. So that means there is a combined effect of this and this together. The total output of GPI diminishes very greatly, and the hyperkinetic motions increase. They keep increasing, and they become intractable. This is the direct circuit. Here I have added this thing. What happens in the striatum? Already the D2 receptor loss is there. Already loss of the indirect striatopallidal tract is there. But now acetylcholine, intrastriatal acetylcholine loss results in the increased inhibition of GPI. And this subthalamic nucleus, GPI and thalamocortical and especially GPI, the final GPI is greatly decreased, and thalamocortical outputs are greatly increased. So that is hyperkinetic motion. Then what happens to the indirect circuit? This thing here, in the striatum, there is a loss of the D2 receptors or a loss of these neurons. Plus, there is a loss of the cholinergic neurons controlling the muscarinic receptors on the D1 receptors, and nicotinic receptors on the D2. and they will produce a very great increase in the GP inhibition, and the subthalamic inhibition is decreased very greatly, and the GPI output is decreased greatly, and finally he is having an intractable uncontrollable involuntary movements, and he will be restless, and he is tired or he is exhausted because of the actions. The hyperkinetic movements, what we were talking about, the Huntington disease, they are not a single entity, but they are a spectrum. Here I have put the spectrum. The hyperkinetic starts with a myoclonus, that means a small muscular activity. Then they become a ballistic, so that means there are flail or unpredictable sudden activity. Then there will be a no pattern and irregular activities all through, that is chorea. Then slow writhing motions, they set in, that's the next part, athetosis. Then finally a dystonia. Dystonia is a state in which the muscle contractions, muscles remain in a contracted state, and it will be difficult. So this is about the hyperkinetic movements. I just explain before I go for the Huntington disease treatment aspect to tell you what is that chorea means. Chorea is a hyperkinetic movement characterized by the rapid, unpredictable contractions. Yes, this person, he is having the contractions, and you just see this particular arrow. So again, he will have the movement of the hand or the wrist. Similarly, here also, he will have the movement here. Here you see the jaw and the face, the eyes, there is a contraction. Even in the legs also, he have the contractions. So this is the chorea, and the movements are involuntary. They are not here. He's not wanting them to have, but he cannot have a control. They don't have a pattern, and their velocity or timing and directions are not. They are highly variable, and they are happening anywhere in the body, flowing from one body part to the another body part, giving a less severe cases appearance of frigidness. That means a slow movements or something like that. This unpredictable nature of the chorea is a feature that distinguishes it from a tremor and dystonia. This is the chorea. Then comes the athetosis. Athetosis is characterized by slow, involuntary, convoluted writhing movements, slow writhing movements like this. You can, if you can see, slowly he will be moving a group of muscles, slow writhing. It's a tremor is only a class of muscles. It's a group of muscles. Those slow, some of them will be having slow writhing movements. They are involuntary, and they are all the time moving and moving like this. And fingers, hands, toes, feet, and some cases the arms, leg, neck, tongue, like that. He always trying to move. Seen in alternating movements of agonist and antagonist group of muscles. That is a flexion or extension, supination, pronation. Slowly, it will not happen like this. Slowly like this, unpatterned. Athetosis, slow rising movements. The eversion and inversion of foot, retraction and pursing of lips, the twisting of the neck, the winking and relaxation of face. All these are part of the athetotic movements. This voluntary movement is slowed due to hyperactive antagonist. Suppose if he wants to do some voluntary activity, so they are slowed. It is associated with rigidity and other corticospinal lesions. Hypotonia is seen in choreoathetosis because there is a decreased suppression of the reticulospinal output. This is dystonia, sustained repetitive muscle contractions resulting in a twisting and repetitive movements and abnormal fixed postures. Here, the drop suddenly he goes into this particular limb muscle goes into a spasmodic repetitive contraction, he falls down. Or he's hyperventilation, that means the repetitive movements of the respiratory group of muscles, so there is a hyperventilation. Here there is a left side tonic spasm, you see how he is dragging the leg. And this lady is having a problem with her eyeball movement, dystonic reaction, oculogyric, that eyeballs start moving, or the pharyngeal or oropharyngeal, such type of phenomena happens. The dystonia can affect different parts of the body, and often symptoms of dystonia, they progress through the stages. I have already mentioned that the final stage is coming with a dystonia, and that will be limiting for the individual's performance. Some early symptoms include the dragging of the legs or a cramping of the foot and involuntary pulling of the neck. So we will have a wry neck sometimes and uncontrollable blinking. Some persons have that habit and associate the speech difficulty. That is about a dystonia. Now, what is the treatment for Huntington disease? Unfortunately, we do not have any specific treatment. It's only symptomatic and keeping the quality of life, this thing, or improving the quality of life. So there are some medications, tetrabenazine is used to reduce the coriform movements. So this tetrabenazine is a drug that binds reversibly with vascular monoamine transporters. So that means monoamine transporters, that means monoamines are dopamine. They are transported inside. So thus inhibits the uptake of the monoamines. So that means the uptake of the monoamines is inhibited into the synaptic vesicles, so that there will be more dopamine availability. So that it also acts as a dopamine receptor antagonist. So these are the actions of the tetrabenazine, but not very effectively curbing the Huntington disease, these things. So the people have tried haloperidol and dopamine antagonists. The results are not very encouraging. Similarly, GABA agonists like diazepams and other drugs were tried, but not with success. But some surgeries were also attempted, that is surgical ablation of the ventroanterior nucleus of thalamus. If you are looking at the GPI and the thalamus, the GPI the relays into the ventroanterior nucleus of thalamus, and they are trying to ablate that particular portion or destroy that particular portion, either surgically by laser or any other thing. But that did not alter the dementic changes, because the dementic changes do not involve the ventroanterior part of the thalamus. Then the people have tried intrastriatal grafting of the striatal tissue from the fetus. So to improve the cognitive performance experimentally, but it is still in the experimental stage. So there are other experimental these things, wherein tissue caspase 1 that prevents the apoptosis, or the apoptotic regulating enzyme has been tried in the brains of the humans and animals. And the knockout of the caspase gene and have been attempted. So predictably, what is the problem here? The problem here is the short term of the chromosome 4. So it is the expression increased CAG repeats, and increased expression of Huntington. The best way to deal, just I'm giving you, proposing you, or thinking, or triggering you, best way to is to diminish the expression of Huntington, a protein which is a toxic, which is producing this. That should be our direction for designing for the treatment. Okay, just giving the direction there, and I leave this part there, and that's about the treatment of the. Till now, we don't have anything. We only say that the symptomatic treatment and just improving the quality of life. And this person is all the time moving and moving and moving, and he's exhausted of the body movements, and he will die of something, either pneumonia or some other components. Now we have another chorea, what is called a Swindenhams Korea. This Swindenhams Korea results in children, especially it is seen in the younger age group, that means 6 to 14 age group. And this is happens after the pharyngitis, especially the pharyngitis from the group A beta hemolytic streptococcal infection. Beta hemolytic streptococcal infection, pharyngitis. What happens? It will produce maybe some the immunological responses and destroys the putaminergic circuits or the basal ganglia circuits, or it will suppress these things. Mind you, here this beta hemolytic streptococcal pharyngitis also produces other defects in our body. It will alter those valvular functions, the valvular deposits there. So they will have either the incompetencies or some mitral valve or the aortic valve defects. And these also produce some the membrane changes in the renal glomerulus. That means this particular group A hemolytic beta hemolytic streptococcus that produces the autoimmune reaction. Here, because of the production of the autoimmune reaction, the basal ganglia reactions take place, and he will have all the choreatic movements. One part, so this will produce a loss of muscle control and awkward gait and distorted hand gestures. So with the treatment of these streptococcal infections and other autoimmune these things, this person may, or the children may recover from this and from this Swindenhams Korea. Swindenhams Korea is in the early age. Huntington's Korea is in the late stage. Swindenhams Korea is a limiting disorder. That means after 6 months to 8 months, he will become normal with a treatment. Whereas Huntington's Korea, okay, it's progressive. We don't have a treatment yet. But what happens in these individuals, if there are female children are affected, because mostly the female children are affected, in that case, these girls, when they go for, when they become pregnant in their later adult stage, and they may develop the chorea, that is a chorea gravidorum. So, something like that. There is a part of the Swindenhams Korea. I have just given you a brief idea about the Swindenhams Korea. Now, I will talk about hemiballismus. Hemiballismus is a sudden or abrupt flail or flinging movements of the limbs. Just somebody throws like this, continuously throwing flail and flinging movements or a dancing movement. So this type of movements is known as a hemiballismus. It is due to the involvement of subthalamic nucleus of the opposite side, the contralateral side, subthalamic nucleus. And this subthalamic nucleus may be because of the hemorrhage or some other defect that would be involved. And this subthalamic nucleus is known as a nucleus of Luys, L-U-Y-S, Luys. I don't know how to pronounce, maybe Luys, nucleus of Luys. Just for your reference. The subthalamic nucleus, now that lesions of that produces this hemiballismus. Here there is a typical involuntary movement affecting the proximal limb musculature, manifested as a jerking, flinging movements of the extremity, suddenly throwing. Now, what is the wrong? What is the problem here? The problem here, you just see that this circuitry I brought in. The problem here, subthalamic nucleus is destroyed. If the subthalamic nucleus is destroyed, there is no communication between the subthalamic nucleus to GPI. So you are aware of this picture. We have the cortex here, we have the striatum here, we have the GPA. This is the indirect circuit. The indirect circuit from GPA to the subthalamic nucleus, from the subthalamic nucleus to GPI, and GPI gives output to the thalamus. So now this output, what happens, because there are no, this is excitatory, subthalamic to GPI is an excitatory glutamatergic pathway. So this is not there. It is not excited. Already it is inhibited by the direct pathway coming from the striatum. That means involving a D1 receptors. Striatopallidary pathway involving D1 receptor. This is active. This is because only thing, this is destroyed. Under these circumstances, the output from GPI is diminished, and you have this. Now, the purpose, because this is having a flinging movement, sudden jerking movements. This flinging movements because these GPI and the thalamic and subthalamic neurons, or even the striatal neurons, they have some oscillatory or pacemaker activity. And these pacemaker activity, if they are suddenly reaching to a firing level, they will produce those activities. So this type of behavior may be because of the oscillations of these particular thing. Anyway, the main issue is the inhibitory impulses reaching thalamus to thalamus from GPI are diminished. That enhances the thalamocortical outputs. They are coming in jerks, they are coming in bouts, and then that would produce the action. Now, what shall be the subthalamic nucleus lesions decrease inhibitory drive to thalamus, thus increase the cortical activity. That's the basic pathology or basic phenomena or pathophysiology of this individual. Now, what shall be the treatment? I'm just looking you or trying to bring in you. So try to give him dopamine antagonists. So that means you diminish this activity. Or you diminish this activity by GABAergic track, because this is a GABA here. You reduce the gamma there. But what happens if you give a GABA antagonist? It will also block here, it will also block here. So thalamus become uninhibited. The best thing is the people have tried the destruction of the ventro-anterior nucleus of the thalamus, thalamotomy. Or the best way is to cut this path. Cut this path is the most ideal. This is most ideal. So that means that would be diminished. So this particular thing, but they are all experimental. Maybe some of them DA antagonist and GABA antagonists have been tried. Now, there is another syndrome, Tourette syndrome or a tic. This is also having a choreatic movement. This is a neurological disorder characterized by repetitive, stereotyped, involuntary movements or vocalization called tics. So some of them, they have the tics like the eyes, they always try to move the eyes, or they have some tics like the lips they are doing, and maybe the movement of the hands or some parts of the body. You may consider them that they are making some tricks, but they are having real tics. So now this is because of the involvement of the putamen circuit, because the putamen circuit is for the pattern activity. So these are associated with a sudden, brief, intermittent movements in case of the motion. Sometimes I mentioned the sounds, sudden, brief, intermittent sounds. You are sitting quietly and suddenly a burst of activity comes or something comes in your mind and you just say it. That is the production of a voice, such as a blinking of the eyes, shrugging of the shoulders. People have this, or tapping of the table. Just you are sitting there and suddenly you start tapping the table, or leg movements, or you blurt out the unusual sounds which have no meaning, and also sometimes vocalize with offensive words. So this is a trick. So some people are there used to give these offensive words. Abnormalities in the basal ganglia, the frontal lobes, that is the prefrontal cortex, and the other circuits in the interconnections. Dopamine, serotonin, and norepinephrine are involved in Tourette syndrome or tic. That is about Tourette syndrome, where putamen and some parts of the basal ganglia are involved. This is important. This particular part is important. This is a Wilson's disease. This is also known as a hepatolenticular degeneration. This is an inherited autosomal recessive metabolic disorder characterized by deposition of a copper in liver and brain. Deposition of copper in liver and brain. So this Wilson's disease is seen in a younger age group between 6 to 25 years, and the females are more affected. And it is due to the mutation of long arm chromosome 13q. And this chromosome this alters the copper transporting ATP gene. Copper transporting ATP gene, that is ATP7B. This alters that. This 13q chromosome alters or affects the copper transporting. And this copper transporting gene is affected, hence that results in the accumulation of copper in the liver and brain, because transport is not taking place and resultant damage. Now let us see what is this copper metabolism. Just briefly, I have covered in 5 points. The daily we require about 1 to 2 milligram of copper in our daily requirement. And it is absorbed from the intestine along with other metals, and not in a great extent, but it's absorbed. And the transported by copper binding plasma protein. This copper binding plasma protein is known as a ceruloplasmin. Ceruloplasmin. That is there as a plasma protein. So ferritin is the transporter for the iron. This is ceruloplasmin is for copper. And copper is excreted through the enterohepatic circulation in the bile. Now, what is the essentiality or what is the function of the copper in our body? So the copper is essential for the actions of enzymes, tyrosinase, cytochrome oxidase, and superoxide dismutase. Tyrosinase is for neurotransmitters. The cytochrome oxidase and superoxide dismutase are the mitochondrial enzymes. So this is where copper is very much required. Now coming back here, so now this copper binding the transporting ATP gene leading to accumulation of copper in the liver. So in this condition, the copper transporting plasma protein ceruloplasmin is low in Wilson's disease, and this leads to toxic accumulation of copper in liver, and it produces the hepatitis, a fulminant hepatitis. Now, this copper also accumulates in the putamen, especially the lenticular nucleus. That means the putamen and globus pallidus. The lenticular nucleus is a putamen and globus pallidus. The excess of copper in the brain produces lesions in the lenticular nucleus, and other brain areas. And these lesions of the basal ganglia are irreversible. Now, this results in a progressive rigidity, intention tremor, and ultimately the mental deterioration. Mental deterioration may be due to the other pathways, because it is not only the pathways of the basal ganglia. Now, the liver transplant has been attempted in such disease, and that helped whatever the metabolism is concerned. However, the basal ganglia disorders, which are produced earlier by the disease process, so they are irreversible. That means you cannot help the neurologically, metabolically, you can help him to reverse the liver functions. So what happens, this copper pigment, the copper pigment also, because of the excessive accumulation of the copper, also accumulate in the cornea. And that is known as a Kaiser-Fleischer phenomena or ring. Kaiser-Fleischer ring is seen with a copper pigment. That is about hepatolenticular degeneration. Then we will see this. I have explained this copper metabolism. Now we will see another interesting hematological condition that produces the basal ganglia lesions. You must have heard about the Kernicterus in hematology teachings associated with the hemolytic disease of the newborn, where there is a RH incompatibility. I think you recall that. This is also known as erythroblastosis fetalis. And this Kernicterus, what happens? The bilirubin level increases very greatly. This bilirubin level, because of the hemolysis, bilirubin level, when it crosses, maybe it may go above 20 milligram per deciliter. Normally, it is 0.4 to 0.8 milligram per deciliter. Now, when it is increased so much time, then also because of the other aspects, the blood-brain barrier is either broken, or in the children, especially this is a newborn, the blood-brain barrier is not developed yet. So that means it crosses the blood-brain barrier, and because you know that it is attached to the albumin, and albumin attached to this thing will not go. So blood-brain barrier carries. There is some the bilirubin transporting mechanisms that would reach to the particular thing. Now coming back here, Kernicterus is a bilirubin-induced brain dysfunction in a newborn or adults with the metabolic abnormalities. Okay, the hyperbilirubinemia may cause bilirubin to accumulate in the gray matter of the central nervous system, especially in the lenticular nucleus. That is putamen and globus pallidus. Now, why bilirubin becomes toxic? Because this bilirubin inhibits the oxidative uncoupling within the neuron. That means it impairs the oxidative metabolism or the mitochondrial metabolic activity. Point number one. Point number two, it produces toxicity to the membrane, that neuronal membrane. Further, it alters the neurotransmitter metabolism. With these three counts, the bilirubin becomes toxic and produces abnormalities such as hypotonia, rigidity, hypertonia, and athetoid features. Now, we can reverse the hyperbilirubinemia. We can treat the hyperbilirubinemia, whatever the means we can achieve at. However, the basal ganglia abnormalities, once produced or once established, are irreversible. For that reason, when children or when the infants, they show some changes in the muscle abnormalities, one has to be very careful, and you have to treat them aggressively. Now, so they may have, if you are looking, the abnormalities like hypotonia followed by hypertonia and opisthotonus or retrocodis. You just see this picture. This is the opisthotonus and retrocolis. This child, you have these movements of the limbs, this limb, and you see that opisthotonus neck position. And here in this infant is presented at the age of 30 days, 30 days old, where serum bilirubin level is 30 milligram per deciliter, and it has produced encephalopathy. So for that reason, one has to be very careful when the children have a bilirubin level very high that may produce the irreversible basal ganglia abnormalities. Now, to summarize, I have these four circuits put together. One is the basal ganglia circuits. We have the direct circuits, striato-pallidothalamic cortical, the striato GPE subthalamic, where subthalamic nucleus is involved. And this is a direct path. This is an indirect path. The direct path is having a D1 receptors and the D2 receptors. The dopamine comes from the nigrostriatal tract. This is the nigrostriatal tract. And we have the intrastriatal cholinergic system, which is modulating with the dopaminergic receptors. This is a normal basal ganglia circuit. Now you come back here in the Huntington disease, there is an abnormality here, starting either with the absence of D2 receptor or D2 receptor abnormality, or the loss of the GABAergic neurons coming from the striatum to the globus pallidus externa. So there is a abnormality in these things, and that produces decreased output from the subthalamic nucleus, and that decreases the output of the GPI globus pallidus interna to the thalamus, and then thus enhances the thalamocortical outputs that produces the hyperkinetic actions to start with. And these are enhanced because of the escalation of the direct pathway, or more inhibition of the direct pathway. Direct pathway is a hyperkinetic pathway. This gets inhibited because of the imbalanced cholinergic involvement. Or indirect pathway is also is not excited. So that means there is a greater inhibition, or the activity of the subthalamic nucleus is diminished. The total output is diminished. So that means both the direct and the indirect pathways are influenced by the cholinergic, intrastriatal cholinergic neurons. This is about the Huntington disease. Subthalamic nucleus, because this hemiballismus is because of the involvement of the subthalamic nucleus. This path is abolished. So there is no, the inhibition to the thalamus is not there. The thalamic activity is enhanced, and then that produces those ballistic or ballismus type of sudden, jerky, flinging and flail movements which are originating. This is just to summarize various basal ganglia disorders in the circuits. I have referred these books, the Kendall's Neuroscience, the Guyton's textbook, and the Genong's Review of Medical Physiology. In addition, I have read many other books, and this is one of the Cold Spring Harbor Perspective of Medicine is one of the book. Now, coming back here, I have created the assignments. Describe the parts, connections, and of basal ganglia. Briefly outline the circuitry in Huntington disease. Or describe the parts and the direct and indirect circuitries of basal ganglia. Show the flow chart when the striatal GABAergic neurons are destroyed. So this is again the Huntington disease. Describe the parts and functions of the basal ganglia. Write the flow chart showing the effects of lesions of the subthalamic nucleus. Subthalamic nucleus. It is about the hemiballismus. Then write notes on Wilson's disease, CAG repeats, Kernicterus, Tourette syndrome or tic, thalamotomy, athetosis, Huntington, Sydenham's Korea, Hemiballismus, Huntington disease, subthalamic nucleus, Korea. In the next class, I will be starting with the cerebellum. I will discuss with the parts, connections, and functions of the cerebellum. Okay. Thank you.